Good morning, good afternoon, and good evening, dear colleagues. Today, we are together again for the World Society of Arrhythmia, the Bradyarrhythmia Education Program webinars. And today, our topic will be about patient management, prevention of infection related with device implantation. I'm honored to moderate this session with Professor Dung from Vietnam. He has huge experience on device implantation, and he is also pioneers of the education on this field. He managed the biggest implantation center in Vietnam. And Daljeet, my dear friend Daljeet Saggu, will talk about this subject, and I'm really thankful for her for joining us. And also Oğuzhan, Ekrem, Turan from Turkey will join us as a panelist. Professor Dung, could you please talk about yourself, and then stage will be yours, Daljeet.
Thank you, everyone. So this is my honor today to be hosting one of the important issues in the pacemaker. I'm currently running the head of the department in Vietnam. We're in charge of implantation for the patient in the south of Vietnam. So we think that we have a couple of experience in this field, especially regarding how we deal with infections and how we do what we do to prevent the infection to happen. So it's also good. This is a good chance for me as well and for everyone to listen to other center statistics to prevent these complications, and hope that we will have we can get one or two things, new things from these sessions together with all the expertise here. Thank you, everyone.
Thank you, Professor Dung. Now, Professor Saggu from India will tell her experience. He's not only an experienced implanter, she's also developed her own center in her region and created excellent pathways in very difficult conditions. I'm looking forward to hear your experience, Daljeet.
Thank you very much, Emin, and thank you, dear friends. Thank you, panelists, for giving this opportunity to me. So I think today my responsibility is to talk about the prevention of how to prevent the infections while doing CIED implantation across all types of CIED implantations. I'm a consultant cardiologist, cardiac electrophysiologist, working at AIG hospital, which is mainly in the south part of the country, which is Hyderabad. So, Emin, the thing is, I thought my responsibility is to talk about mainly the preventions, and I'm not going to talk about how to manage if there is an infection and all. But yes, I'll be talking about all the preventive measures. I'll be showing my own example cases of my own cases and all. Along with that, I have used this consensus statement, which is a joint consensus statement between EHRA, HRS, and APHRS, which talks about how to prevent the infection. So why this topic is very important or very pertinent. I'm sorry, the slides are not moving. Okay, so why this topic is very important? Because we know that millions and billions of devices are implanted every year across all the world. And if you go to one of the largest registry, that is the Danish registry, it says that number of infections which happens after device implantation, first primary device implantation, is 4.5 per 1,000 device years, But as soon as it goes to second implant, so if there is a pulse generator change, when you go to second implant, the chances of infection increases by more than 50%. So it is more than double the new device. So it is important to know, because I know that whenever we say that it's a pulse generator change and we feel that it's an easy case, it's a simple case, same site we are repeatedly doing the procedure, chances of infection is high. So your sterility measures are very good, specifically if you're doing a redo procedure. And always remember that the chances of infection are more if your type of device is a bigger device, if number of leads are more, if it's a biventricular pacemaker, if it's a defibrillators, if you have already some leads, indwelling leads there, if you have already a cap lead sitting there. If you have more than 2 leads implantation, chances of infection is very high. So you have to be very cautious about it. That is one point. Second, there are patient comorbidities. It is very important to know what is the background of your patient. If you have a clean patient, which is just only having a heart block or heart failure, no major comorbidities, then the chances of infections are less. But if the same patient who's diabetic, specifically uncontrolled diabetes, you have to be really cautious. If you have a patient which has a skin disease, you have to be very cautious. If you have a patient who are nasal carriers of some infection, you have to be very cautious. If you have a patient who's having end-stage renal disease, specifically patient who's on dialysis, it's important to know, because one thing, they will have a AV fistula. One thing, we should not go on the same side where there is an AV fistula. You have to go to opposite side. Chances of hematoma is high and chances of infection is high. Patient who are on some or the other immunosuppressant, specifically if the patients are on steroid, chances of infection is high. Post-transplant, we get lot of patients who are post-renal transplant, post-liver transplant, who are on immunosuppressants. Chances of infection is very high. You have to be very cautious. Patients who are having history of previous infections, previous pyelonephritis, previous urinary tract infection, previous lung infection, having interstitial lung disease, chances of infection is very high. So before we start the procedure, knowing our patient very well helps us to decrease the chances of infection. What is the mechanism? The most important is, because this is the hardware, this is the metal which attracts the infection. So infection chances or colonization can happen on the device, on leads, on both. That can happen during implantation. So the data says the maximum infection happens are during the procedure than the post procedure. So it is related to a procedure. We have to be very cautious how we are doing the procedure, how your patient is handling the device, or how the wound handled subsequently is also very important. And that most chances is there is a direct seeding of the bacteremia on the leads and all, or on the device is very high. So how we handle the device, I'll talk about it, which will increase the chances of infection. So as I already spoken about, if patient has some skin infection, or there are many patients who are chronic nasal carriers of Staph aureus, the chances of infection will be very high. So skin flora is important. Secondly, how many people are there in the lab? It is really important to see that unnecessary person should not be there in the lab. Less number of people in the lab, less movement in the lab, lesser are the chances of your infection. You should be treating your cath lab like an operator room, and you should be doing a proper 3-minute scrub, which is a surgical scrub, before you start the procedure. And it is always better to wear 2 gloves instead of handling single pair of gloves. I'll talk about it now subsequently. So what are the measures? The major measures are to be taken while pre-procedural, like taking care, tailoring the therapy, which kind of patient you are taking, when you gave the antibiotic, peri-procedural, how are you handling, and post-procedure, how the wound is being handled. I'll talk about it. So when you are in the operating room, it is very important how's your lab, how is the lab air filtration, you should be aware about it. How many numbers are there in the lab, how many people are there in the lab. I have already spoken about hand washing. It's always good to wear double gloves. Many centers, the person, operator himself or herself do the complete draping. So any person who's doing the draping, after finishing the draping, it is better to remove the upper glove and then change the upper glove before you start the main procedure. It is always better to use a disposable drape, not the reused kind of drape. It's, if it is possible, it's always used to use the iodine impregnated plastic sheet. I'll show what I'm trying to talk about. And everything, the patient's skin should not be exposed while doing the procedure. Like, for example, like this. I believe this is a very bad way of doing the procedure. You can see that whole skin is exposed. You can see the sheets and the lead is exposed. However good cleaning you are doing, it should not be, the skin area, surrounding skin area should not be exposed, and lead should not be touching the skin area. The chances of infection will be very, very high. So the way we should be doing the draping should be like this. As I already told, that it's like a surgical drape. Whole of the area which is your implant area should be completely covered with the iodine impregnated proper iodine, we call it, and there should be no air pockets in this, and there should be no skin exposed while doing the procedure. This is the way I'm talking about. You can see the only area where you are doing the procedure is open. All other areas are completely covered. There is no skin seen. Then the chances of infection will come down drastically. Third, while doing the procedure, while we are putting the stylet, while we are checking the position of the lead, while we are screwing or de-screwing, it's always better, it's good to cover the incision with a sterile gauze piece. You should not keep the wound open while you are doing the screwing, unscrewing, or whatever it is, because the more the time, the longer the duration the wound is open to the air, more is the chances of infection. So it is always prudent to cover your wound while doing the procedure. Next, while you're doing a dissection, you should be doing a clean incision. As far as possible, it is better to do blunt dissection. Cautery should be utilized. Minimal hand utilization should be done. More of a clean cautery should be used. It is better to avoid cautery very much near the skin, because the chances of healing will be delayed, because when you do the suturing, then the skin will get nicely tamponade, and some skin area should be left which should be healthy for while closing the skin. And the dissection should be done till the fascia covering the pectoralis muscle. Never ever do the incision or implant the device within the subcutaneous tissue or within the fat. I'll show you the reason why I'm saying this. Next, it is really important. You should never ever open your hardware before you're ready to utilize it. For example, there are few operators who create pocket first and then take a puncture. There are few operators who take puncture and then create the pocket. Whatever it is better. But once your pocket is ready, once your punctures have been taken, when you're ready to put a sheath, it is better to open the leads at the time just before when you're trying to use a lead. It's not a good idea to open the lead and keep on the table for a longer duration. Same holds for the device. Once your leads are implanted, parameters are checked, leads are sutured properly, it's better you should change your upper glove, the upper part of the glove, and change to the second glove, clean the pocket, and open the device. It's not a good idea to open the device because it's again a metal. It collects infection very quickly. So it's better to open the device just before you want to use it or you want to connect it. It's a good idea. Pre-procedural, going to the patient characteristics, it's really important that see to it patient is not harboring any infection, not having any upper respiratory tract infection, no signs of fever are there. For some reason, patient is not taking longer antibiotic, beware about it. If there is no emergency and if it is possible to delay the procedure, if there is any evidence of infection, it is better to treat the infection and then take the patient for the procedure. As far as possible, unless really required, avoid TPI. And if you're putting the TPI, have a good habit of, as soon as your procedure is done, immediately within the lab itself, remove the TPI. Don't leave the patient on TPI for longer duration. I think I've already spoken about the glycemic control. If the patient is diabetic, it is really important that the patient's diabetes is well controlled and there are no open wounds in the body in the patient who's having diabetes. When you talk about microorganisms, the most common microorganisms are gram-positive. That's the reason I'll talk about which antibiotics we use. Coagulase negative Staph aureus are 1/3, Staph aureus are 1/3, MRSA are 1/3, and gram-negative are less common. So you should be aware that which are the bacteria which are commonest causing this acute infection. So for Staph aureus decolonization world over, there is a data doing a proper chlorhexidine body wash, the way we do it a day prior or the same day if the patient is admitted in the preparation room, from neck till the groin, a proper chlorhexidine wash has been given to the patient. If we feel that patient is a chronic carrier for Staph aureus, nasal carriers, it's better to use mupirocin ointment in both the nostrils for 48 hours prior to the procedure. And whenever you give antibiotic, because as I already spoken about it, the commonest organism is gram-positive bacteria, that is Coagulase negative Staph aureus and Staph aureus. Cefazolin usually we use, and it should be given within 1 hour of taking the puncture and giving a nick to the skin. Flucloxacillin also can be used, or in the patients, if you feel that stronger antibiotic is required, if the patient is immunocompromised, diabetic patient having some infection or recent history of infection, vancomycin can be used. It is better to use 2 hours prior to the procedure. Peri-procedure, as I spoke about it, a topical hemostatic, like chances of bleeding should be less, because more the hematoma, more is the nidus for infection, more is the chances of infection. And once you have completely put the leads, before putting the pocket, saline irrigation, removing all the debris, all the fat tissue with the saline is important, and keep the pocket very clean. It is very important. World over, there is no benefit. Data says there is no benefit of using antibiotic irrigation or soaked gauze. There is no data of added advantage, because if you prevent the infection, if your sterility is very good, there is no added advantage of irrigating with antibiotic. But saline irrigation, there should be no blood collection and wound should be completely dry. If you have an hematoma, it is very important that please don't put the needle from outside the pocket and try to aspirate it. You can give compression dressing for 24 to 48 hours. But if you feel there is a pressure hematoma and you are not able to get rid of it, it is always better that in the sterile condition, take the patient again in the lab, open the wound, remove complete hematoma, and then identify the bleeding area, use cautery, clean the wound. And again, never ever, there is a data which says that if you put a needle from outside, you are introducing more infection. So never ever in your outside area or in the pre-cath area, never ever put the needle and try to aspirate it. If you feel that it's a pressurized there, it's better to take the patient again in the lab. So there are a lot of cases which causes a pocket hematoma or wound edge is not been properly covered. And whenever there is an hematoma, it is always better to remove the alternate suture, allow the blood to come out and cover the wound again. This is few of my patients. So what are the solutions to avoid hematoma? Because this is one of the strong reasons that patient may get infection is, as I already spoke about it, use a clean, judicious use of cautery, watch for bleeders properly. If it is possible that you can avoid antiplatelet or oral anticoagulation, it's better to hold antiplatelet and oral anticoagulation. Don't bridge with heparin. There is a bridge trial. It's better to avoid heparin for 48 hours to 3 days before you do the procedure. It should not be used. And I will talk about a drain, which I know that world over no one talks about it, but our center uses it because we have a lot of rheumatic heart disease patients, lot of patients who are having a single or dual metallic valve, specifically metallic valve in the mitral position, where the patients are on acetrom or warfarin, that is VKA, and we cannot stop any of this. We usually do the procedure on acetrom with INR less than 3, maybe between 2 to 2.5 to 3, and we don't do any bridging. But while doing the procedure under the sterile condition, we put this 50 ml minivac drain, which we leave for it's usually 24 to 48 hours. Once collection is less than 10 ml, well, then we remove the drain. And we have already published the data, a large data on this, that even if you utilize this drain, one, your chances of hematoma comes down drastically. Second, there is no increased chances of infection despite of using the drain, because when you are using a proper sterile conditions while you are utilizing the drain, only thing is when you put a drain, there is an extra stay in the hospital, maybe for 24 to 48 hours. In these patients specifically in whom you cannot, for example, CHAD-VASc score is more than equal to 4, or patient is having a metallic valve, chances of thrombosis is very high. In those cases, this drain can be utilized. So as I already spoke, like if you are pushed against the wall and you cannot stop anticoagulation, don't do bridging, continue your anticoagulation and put a drain if you want to. Usually what we do, if the patient is on one of the DOACs, the day of the procedure, morning dose of DOAC we don't give. We do the procedure and the same day evening, usually we start DOAC. And if the patient is on VKA, we try to make it sure that INR is not more than 3, it is less than 3, and do the procedure. If patient's conditions permit, we try to avoid antiplatelet, but still if the patient, if you are forced to do procedure within 4-5 days of anti-wall MI or any ACS, and then you have put a stent, long stents, and you cannot stop antiplatelet, we do on antiplatelet, but in those patients also we try to put a drain and leave it for 24 to 48 hours. Next is the excoriation. Excoriation is truly not the infection. I strongly feel that these kind of excoriations which happens are really procedural related. That means we are not trained to do our procedure well, because these are not true infections. These are excoriations which are pressure excoriations which will push the device out. And once this happens, we are all aware, when the device is exposed to the external environment, there is no other way but to remove the whole system. We have to do extraction for the patient. So this procedure I did in the morning only. There's one extraction I did in the morning. And if you can see here, this was an excoriation coming here. This wound was excoriated, and as soon as I gave a nick here, and you can see that lead is sitting above the pulse generator. I believe that this is not a good procedure done. We all feel that device implantation is just putting the leads and then somewhere we put the pulse generator. It's not like that. How are you creating the pocket is very important. As I said, that your pocket should till the fascia of the pectoralis major, because you should not be implanting the device. This device was implanted within the subcutaneous tissue, and you can see that whole lead is coming on the device. This is different patient. These kind of loops, when they come out, they're all over the place. These are the loops which with the pressure and all, they come out. So if you're doing a clean and neat procedure, all your lead loops should be neatly, properly, without any kinks, should be sitting below and behind your pulse generator, so that they are not poking specifically laterally where they form a hump and then excoriate, and ultimately it becomes difficult to handle these patients. So when you're doing a dissection, your dissection should be till the pectoralis major. If this is your groove, if this is your incision, your pulse generator should be below and behind your incision, and all your lead loops should be below and behind the pulse generator neatly, so that they don't poke and cause excoriation. So as I said, that there should be a proper deltopectoral groove. Pocket should be medial and it should not be coming out. Treat all the bleeding points and avoid excessive tension. You should make it sure that your pocket size is clean, roomy. And when you make a roomy pocket size, it is very important. Then when you tie the device should be tied not only to the floor, that is floor of the muscle, but also to the roof, because specifically in female patient, when the device moves, so if you don't take both floor and the roof suture, the device slowly comes down. We would have all seen that experience, operators. Slowly whole system comes down. It reels back the lead as well. But if you have taken a good muscle suture, that is pectoralis muscle suture to the device and to the roof, despite of roomy pocket, if at all at a roomy pocket, it won't move and it won't go down, or it will not come and drop into the axilla. When we talk about a pocket creation, the commonest is, safest is, it's okay to go for a pre-pectoral pocket, as I've already spoken. Subpectoral, usually we make a subpectoral pocket if patient is very thin, very emaciated patient, and we feel that chances of excoriation is high. We go subpectoral, but we make it sure that these patients are not on anticoagulation because chances of bleeding is high. We are very cautious. Secondly, when we go below the pectoralis major, it is better to try to separate the fibers in the direction of the muscle fibers. Instead of cutting it, it's better to keep separating the muscle fibers to go below the pectoralis major. Everything should be done under direct vision. It should not be done blind. Few people are in a habit of using loops so that you are able to see tiny bleeders also. I have done few submemory cases, but those are the young females, unmarried females, who don't want that tiny bump which is seen specifically with the bigger devices. Few people have done axillary, few people have done specifically abdominal is done mainly for the epicardial devices. It's better to give analgesia. If you don't use adequate analgesics, the branch or the vein usually gets very quickly, it gets collapsed, and then you do multiple punctures, then you puncture artery, then the chances of hematoma increases. That's why it's better to give a very good analgesia. As I already spoke about it, your whole device should not be sitting in the axilla. Chances of infection is high. Next is, it should be subfacial, and it's better to do blunt dissection with scissors or try to use cautery. If there is an oozing, you can use adrenaline soaked gauze pieces and watch out for each and every bleeder. And as I've already spoken, that whole wound, when while doing the procedure, it's better to cover with the gauze piece. So as I said, the reasons of erosion are PG pocket in the subcutaneous or in the adipose tissue. So however, obese, thick, big patient, have a lot of patients and go till the pectoralis major. And you should never suture the leads within the subcutaneous tissue. It should be tied to the muscle, and muscle suture should not be so tight that it is causing the necrosis of the muscle. So when you take a bite on the muscle, that should be little bit lenient suture. But when your suture is along the sleeve, then it should be little bit tighter suture. Pocket should not be too small that it is creating a tension. It should not be too lateral to drop into the axilla. Roomy pocket should be there, but PG should be secured, as I said, both to the floor and to the roof, so that it doesn't drop or move, so that chances of infection is less. And we all know that if the wound or any part of the device is exposed to the external environment, it's a big procedure. The only treatment, it's better to do extraction. I know world over there is some data who try to salvage these devices. You can do that. But ideal treatment is extraction and removal of each and every hardware. So same thing, if you go for the consent statement, what it talks about is, as I've already spoken about, that utilization of local antiseptic or antibiotic in the pocket has no added advantage. Yes, when you talk about sutures, when you use sutures for skin, it is better to use a monocryl, or it is better to use a proline kind of suture, non-braided sutures, because the more braided the sutures are, more is the chances of your infection. Post-operative antibiotic, as I said, you should be giving antibiotic within 1 hour of taking a puncture. Usually second antibiotic is given after 6 hours. If your procedure duration is small, there are no infection, there are no high risk of infection, more than 48 hours of antibiotic is not required for the patient. Longer antibiotics are not required. Patients should be instructed to clean the wound, keep the wound area very clean. Usually for our patients who are not on any anticoagulation or antiplatelet, we use subcuticular suture so that the next dressing is required on 4th and 5th day, and after that no dressing is required. But the patient who are on anticoagulation or antiplatelet, it is better to use intermittent sutures so that even if there is a smallest of collection or ooze, it will have some space to come out between the sutures. Because if you use all layers continuous suture, you're not leaving any space for anything, any collection to come out. It will keep collecting inside and it will form a big hematoma. For example, if there is an hematoma, you can give compression dressing for 24 to 48 hours. Try not to open it, but if it's a pressure hematoma, don't put needle from outside. It's better to take patient to the lab in a sterile condition, reopen the wound, clean it, search for the bleeder, and then close in multiple layers with intermittent suture. It is always better. As I already said that if the patient is already having an infection, it is better to delay the procedure. It's better to avoid low molecular heparin. Please don't bridge your patient. As far as possible, avoid temporary pacing. If required, jugular pacing is better than the femoral. There is some data which says that infection chances are less. Even if you have used a temporary pacemaker, it is better to remove it immediately after your procedure. Don't keep it for longer duration. Avoid putting the jugular on the same side. Like, don't do the device on the right side if you have put a TPAP from the right IJV. Avoid central line on the sides where we have put a device, or chances of infection may go up in these kind of patients. Less number of patients within the lab. If the patients are colonizing, if you feel that there are many times we take a nasal swab, if there are few patients who come with repeated infections, we take a nasal swab and see that if there are slow growers of some infection, then we give a prophylactic antibiotic. When you clean the patient, when you're doing the shaving, there is a data that razor should not be used instead of razor. Clippers are always better. Antibiotic to be given within 1 hour of giving an incision for the procedure. Now, I think we all are aware about this antibiotic pouch or TRX. There is not so strong data about it, but if we feel that there is a background higher chances of infection in the patient, which I've already spoken about, patient is end-stage renal disease, diabetic patient, uncontrolled diabetes is there, or you are not able to, you are forced to do the procedure, you are not able to delay the procedure, you can think of using the antibiotic pouch or the TRX. If your patient is on immunosuppressant, specifically patient is on steroids for some or the other reason which you cannot stop, then TRX can be utilized. This is the antibiotic pouch which contain rifampicin and minocycline, which is released over 7 days, and whole of this pouch gets reabsorbed within 9 weeks, and the two sizes of pouches are available. Pacemaker smaller, and for the your ICDs and CRTDs a bigger pouch is available. This is my last slide. I know it's a busy slide, ladies and gentlemen. It is from the HRA consensus statement, and this is the collection of whatever I've just spoken all over, like patient related, like factors, or modifiable factors are there, non-modifiable factors are there. Modifiable factors are there if you feel that you can delay the procedure if patient has infection, if patient is on anticoagulation or antiplatelet, if you have time to hold, try to hold and then do the procedure. Try to avoid prolonged procedures. If there is an hematoma, it is better to manage conservatively. Try to avoid the hematoma, avoid the characteristics of the hematoma. Non-modifiable risk factors, you can use a preventive measure, you can use a TRX pouch, you can use drain. We can discuss more about the drain, and try, if there is an infection on one side, it's try to go on the other side, and try to do a smaller procedure as possible. try to discharge the procedure at the earliest possible. It is not a good idea to leave the device cases in the hospital for longer duration. Usually for us, if the patients are not anticoagulate and not on anticoagulation or antiplatelet, usually within 24 hours or sometimes same day discharges are there. The more you keep the patients in the hospital, more is the chances of infection. I will stop here. I'll leave this slide if you have any questions on this slide, and I'm ready to take any questions if you have. Hope I was loud and clear. Thank you very much.
Excellent talk, Professor Saggu. It's excellent talk, distillated from the thousands of implantations, a huge experience. And for my side, it was all clear that I don't have any question, but I'm sure Professor Dung will add some more information. It was very practical, straightforward presentation. Thank you very much. Professor Dung, you also have a huge experience on device implantation, and your center is one of the busiest center in the Southeast Asia. Do you have any comments?
Thank you for a very good speech regarding how to manage both for the patient, both before procedure, during the procedure, and also both the operation for any implantations. And all of the strategies was very applicable. I think this is very useful for almost every lab. But there's one problem that I think that's the one experience from my side. That is, for example, because you say that there would be some case where we need to do the generator replacement. This is one of my experience, that because initially in the reverse couple of years, we will check the lead integrity during the case. That is, we will unblock the generator first, and we connect that to the programmer, and then we check for the integrity of the lead, pacing lead. But now we usually do it before the procedure. That is, we would like to use the programmer before we do the incisions. We check for the integrity of the lead first, and then when we go on for a lead replacement, I mean for the generator replacement, we will directly unblock the old generator and block in the new generator and do a suture. I mean the suture to close the wound. So it will cut down the time and also the infection rate. In my experience, because we will not need to use any like extra time to check the integrity during the case. That is one of the things that I think also applicable in several centers, especially when we have the expired battery, and that is I think that is also a good experience that any implanter can apply at their center. Thank you. That is just my experience. I don't know how about the rest, but I also it has been a very wonderful experience from the speaker to have to get to me to know more about how to prevent the infections. Thank you.
Thank you for adding those important points. I think they make sense, all. I think this is added to the presentation. Thank you, Dr. Dung. Thank you.
Yeah, I think it also emphasized the importance of one of the points that Daljeet mentioned. Everything starts with the first implantation, and if you prepare your packet in a correct way and put the leads under the device, when the time of replacement comes, then only unplug the device, and then plugging the new generator is usually sufficient if you have no problem in the pre-procedural test. Then you can close packet and closure. Usually integrity is not a problem if everything is is done in the first operation. Very, very, very important point, Professor. And we are also together, İzmir. Oğuzhan, do you have any question or comments?
I'm really thankful, Dr. Saggu, for the informative presentation. And maybe I missed something with the skin preparation. We normally use chlorhexidine sprays for skin preparation before the procedure. Is there any differences between iodine or chlorhexidine for the audience that maybe can you say something about it? And also, I would like one more question to you about the prophylactic antibiotics. The stronger ones like vancomycin, what is your percentage rate that you are using in your practicing? And this is very important for us. If we involve diabetic patients, our patients has almost everyone diabetes, and we should use a stronger antibiotics. Yeah, we are sure that we are using also immunocompromised patients, but which criteria do you take into account for a stronger antibiotics?
Thank you for those questions. I think they're important. So to the first question, iodine and chlorhexidine. So although world over there is no difference in the data, if you see guidelines and all, they go for chlorhexidine. Our center also used to sometimes use iodine, povidone iodine. But one of a patient, we realized that Pseudomonas can grow in povidone iodine. This we were not aware about. So since the day we saw that it can easily grow, our microbiologist told that Pseudomonas can grow into the povidone iodine, we stopped using it altogether. So for all our patients, whatever, the more data I see, the more infection data or whatever I see is everywhere it's a chlorhexidine. That is the reason we are in habit of using chlorhexidine. That is one. Now going to requirement of higher end antibiotics. For us, the utilization of higher end antibiotics is very, very, very rare actually, if you ask me, because I feel that if your procedure has been done in a proper sterile condition, the chances of infection is very less. Never said that, for example, if you have a patient who is having a recent history of UTI and I'm not able to delay the procedure, or if I have a patient who's on immunocompromised state, yes, then I'll see whatever sensitive antibiotic is, then I will use higher antibiotic. But depending upon the sensitivity, you're absolutely right. The chances of utilizing vancomycin is more than any other antibiotics. But for us, patient are, even if the patient, because we do a lot of patients who are sarcoidosis who are immunocompromised. So we try to hold the steroids for 4 to 5 days, do the procedure and don't give steroids for next 15 days and then only restart the steroids. If you are able to hold it, that is always better. Or for example, newly diagnosed cardiac sarcoidosis patient who came up with heart block and we know it's a cardiac sarcoid. What we do is we give all the vaccines available. Like usually we give pneumococcal, influenza, herpes vaccine, we implant the device, we don't start steroids. And after 15-20 days, when the wound is completely healed, because sarcoidosis immunosuppression is not an emergency requirement. So once the wound is healed, then only we start the immunosuppressants for the patient. But yes, if the patient is already immunocompromised and highly uncontrolled diabetes, any evidence of infection, depending upon sensitivity, we give antibiotics. Sometimes we take help of our infectious disease people also.
Thank you so much about comments.
So we came to the end of the webinar series of your Society of Arrhythmia and Bradyarrhythmia treatment webinar series. And if no one wants to add something, I will close this session. Once again, I would like to thank Professor Dung, Professor Saggu, and Dr. Oğuzhan Ekrem Turan. Hope to see you in person in this webinar series is terminating with the last episode. We started from the Ecuador, and now to the Vietnam and India. I think it was a very good ended. Thank you very much. See you soon. Bye.